Good evening. My topic is outcomes of photorefractive epithelium in high myopia. I have no financial interest. As we know, myopia is a significant public health problem and its prevalence is increasing over time. And the main treatment options include contact lens, spectacles and refractive surgery. And surgeries reduce the dependency on contact lens and glasses. Mainly the refractive surgery include laser-assisted in situ keratomilutious, SMILE, TRANSE. Why TRANSE? Transepithelial photorefractive keratectomy is an advanced stretch-free laser refractive surgery that involves the removal of the corneal epithelium without suction, flap or blade or without the use of alcohol. It is one of the quickest vision correction procedure. Coming to the surgical step, first we instill topical anesthesia and measurements were taken by static cyclotorsion correction and single step of laser delivery to ablate the cornea and mitomycin C 0.02% for 30 seconds applied and the cornea immediately cooled with balanced salt solution. A note about mitomycin C. Mitomycin is an alkylating agent with cytotoxic and anti-proliferative effect and it reduces the myofibroblast repopulation and used for prophylaxis against post-operative corneal ACE formation. The aim of the study is to evaluate the safety profile of the TRANSE procedure in high myopia and to compare the refractive outcomes of TRANSE. It was a retrospective study conducted October 2021 to March 2022 with 27 eyes of 40 patients of age 20 to 35 years with a spherical equivalent more than 6 diopter who underwent TRANSE. My inclusion criteria: patient about 80 years of age, spherical equivalent more than 6 diopter, stable refraction at least 12 months and no evidence of abnormal corneal topography. And I excluded thin cornea, concurrent ocular disease, systemic disease and previous ocular surgeries. Pre-operatively assessed visual acuity, slit lamp, biomicroscopy and dilators fundus examination, corneal topography and pachymetry. And the study participant received topical antibiotic for 1 week, lubricant for 3 months and tapering dose of topical steroid for 3 months and follow-up done first week, first month and third month after the procedure. Coming to the result, there were equal number of male and female in the study group with a mean age of 24.6 plus or minus 4.16 with a spherical equivalent with a mean of 6.9 plus or minus 1.59. And the post-operative best corrected visual acuity, 86 patient achieved 6/6 vision and 7.4% achieved 6/9 vision and 1 patient achieved post best corrected visual acuity of 0.18 logmar better than pre-best corrected visual acuity. These are the pre-operative parameters which include average corneal thickness, residual stroma, ablation depth and we calculated percentage tissue altered of mean 39% plus or minus 0.093. And post-operative logmar visual acuity, final best corrected visual acuity at 3 months was 0.04 and the post-operative ACE developed at 3 months, only 2 eyes that is 7%, that is 1 patient developed ACE as the patient did not apply the post-operative steroid as per schedule. Coming to the discussion, Leslie et al. Studied 6-month follow-up done in 32 eyes where 94% of the eye myopia achieved uncorrected visual acuity of 6/6 and Shoaib et al. 3-month follow-up of 30 eyes achieved 6/6. And in my study, 3-month follow-up done in 27 eyes, 86 achieved 6/6 vision, 4 eyes which 2 eyes had amblyopia and 2 eyes of the same person developed post-operative haze because of post-operative topical steroid did not applied. And about the post-operative ACE, Agar Kaiserman et al. In 7,535 eyes, only 2.1 developed ACE and Ash Balkat et al. 126 patients developed 9.5% only attained the corneal ACE and in my study only 7% developed post-operative ACE. So, conclusion, TRANSE produces an excellent visual outcome in patients with eye myopia. It is a safe procedure in high myopia with a very low incidence of complications such as post-operative ACE and can be used to correct higher degree of emetropia. LASIK may not be feasible in patients with high myopia due to concern regarding post-LASIK corneal ectasia. In such cases, TRANSE is a safe and efficacious alternative. These are my reference. Thank you.
Few questions. The first question is the initial vision assessment that was done. It was done as soon as the procedure is over, or was it done after the B cell is removed after 5 days? The initial visual acuity that you have checked.
Week.
After 1 week you have done it. Okay, fine. The second thing is, what is the duration of the mitomycin that was used?
30 seconds.
No, 30 seconds for all type of refractive errors, or suppose if it was a -4 or a -7, the duration was the same as 30 seconds?
Yeah, applied 0.02% mitomycin for 30 seconds.
Then how do you account for your lower haze rate as compared to the other techniques, like PTK with your PRK, or epitel removement, like mechanical versus PRK?
TRANSE is touch-free laser, single step. We can ablate both epithelium and stroma. In LASIK, there is flap-related complications.
No. See, my question was, now we have different types of ways of doing the PRK. This technique, what you have said, is one of the techniques. Now, how does it fare with other techniques like your mechanical removal with PRK versus
conventional TRANSE that include using the alcohol? We manually remove the epithelium.
No, I'm talking in terms of haze. So you're not compared it to any other technique. You have just done only this.
Only TRANSE.
No, for you to say this is good, you need to compare it, right?
Yeah.
You have not done a comparison at all.
No.